Ladies and gentlemen, good day to you, regardless of where you are. We have a few technical issues today with Dr. Halima Moumouni, who is a technical manager, who is supposed to be the moderator for this session, but we are going to have to get started without her until the technical challenges are figured out. For those who just joined us, let me just remind you a couple of housekeeping things. So just like other countries of the sub-region, Niger is dedicated to boosting and intensifying the indicators of maternal indicators in the country, to implement the resolution of the Ministry of Health of the ECOWAS, which encouraged different countries to scale up the delegation of those tasks with regards to family planning. So it's basically a scaling up mechanism that was deployed. And within this framework, Pathfinder work through a specific project has been working with the Ministry of Health to scale up delegated services in specific areas in Niger, especially in Dosso, Zinder, and Tahoua. And through this experience, we have launched a series of webinars to share the experience. And this webinar is going to focus on the experience of the DMPA-SC, but also the implants or the delivery of implants through healthcare workers. And today is the third session, which is the intensification of community distribution of the DMPA-SC in Niger. So my dear participants, I just want you to make sure that you are on the right channel. If you want to listen to French, click on the French channel, in English for the English channel. And we will have simultaneous interpreters working with us so that you can listen to what's being said. Please feel free at any time to add your questions and comments in the chat box. So now, let me introduce you another speaker who is Akim Assani Osseni, who's expert in this type of interventions with more than 10 years of experience in research and the implementation of projects with regards to SRHR in Niger. Akim is currently technical manager and also manages community-based services for Pathfinder in Niger. Mr. Akim, the floor is yours. Thank you very much, Zaku, for this great introduction. Ladies and gentlemen, good day, good morning, good afternoon to you, regardless of where you are. It's my honor and pleasure to be here with you and to share this series, this webinar series on the intensification of community distribution of DMPA-SC in Niger, while focusing on the experience of the DMPA-SC administration by community-based contraceptive distributors in the region of Dosso, Tahoua, and Zinder. Slide. My presentation will be as follows. So first, there will be an introduction and a context of the country, but also the different goals linked to this intervention, but also the different areas where it was what it was focusing on. But then we will talk about the the different supports and the different methods related to this experience. We will share results, but also the challenges that we encountered while being implemented. We will share the lessons that we drew and conclude with recommendations. Next slide.
En introduction, je dirais depuis l'urgence, l'AGIR lancée en 2000.
I would say as an introduction that since the emergence of Ouagadougou, since the urgency to act launches in 2011 by the Ouagadougou Partnership, the various health actors in West Africa have committed to improving women's access to modern contraception, in particular by dissemination and replication of innovative best practices observed in this region. Injectable contraceptive are among the most widely used pregnancy prevention methods in the world. In Niger, they come in second place, and they offer women safe, effective, convenient, and confidential contraceptive protection. Slide, please. Next slide, please. It was this injectable has been introduced in the minimum package of activities for health HUDs in 2014 in Niger. To ensure scaling up and access to the community level, the country has developed a task delegation policy. This policy has expanded women's choice of contraceptives at the community level through the introduction of the policy, and it has expanded the introduction of implants in health HUDs, and also at the level of community-based distributors, volunteer promoters who distribute pills and condoms. Next slide. Which are the objectives? The general objective is to operationalize delegation of FP tasks to the community level through the administration of DMPA by community-based contraceptive distributors and the provision of implants in health centers. The specific objectives are to mobilize national actors, the human resources and family planning actors to make available national training documents and tools for CAD agents on DMPA. Also mobilize community leaders to support CAD agents in administering the DMPA for clients in their community. Also build capacity and equip targeted agents to administer these DMPA to FP clients in their communities, and also build capacity and equip PHWs to provide implants to FP clients in health centers, and also establish a functional monitoring and data collection mechanism to document the experience in the Dosso, Tahoua, in the regions of Niger. So the duration was over 3 years, from July 2019 to August 2022. It was developed in 3 regions, Zinder, Dosso, and Tahoua, that you can see in orange on the map of Niger. And there were 70 CAD sites for 140 agents for Zinder region. In the Dosso region, it was 50 sites, CAD sites, and 100 agents, and in Tahoua, 20 sites for 40 agents. So in total, 140 sites and 245 agents. Next slide, please. Ladies and gentlemen, this is a reminder of the Niger health pyramid. Our country is based. Let me remind you that this is how our health system is structured. So you can see there are 2 levels, well, 2 administrative levels. with one, you say level 1 peripheral at the bottom, and then the intermediaries, and then the central level. So you can see from bottom to the to top that we have health district, 72 health district. That's the level 1, and then level 2 is made of 8 DRSP, and then the level 3, as you can see, is the central level. As for healthcare structures, you can see the operational level with its network of health facilities around the network in the district. And of course, the intermediary level with the district hospitals and the regional hospitals and centers. And then you can see national hospitals and mother and child services. As you can notice, the RSSP are at the bottom, and the health huts are at the bottom. Next slide, please. So the CAD in Niger, in our context. So this is what we call community-based distribution, and it is when trade lay members of the community are responsible for providing information and services to the population, certain services. So who is a CAD agent? It's a member of the community who actually carries out usual activities, but agrees to devote part of his time to deliver services to the community, to provide information on RH and FB, directly distribute contraceptives, and they offer other services to other community members. It's a so-called field agent, educator, promoter. And what are the assignments? It's really to inform, raise awareness, and educate the population around gender issues, HIV, vaccination, AIDS, etc. Also to distribute RHFP products, pills, condoms, DMPA, for example. Also to refer cases for those patients who want to have other types of contraceptives, for example. Also to collect data on activities that are carried out, conducted, manage products, make home visits, like to follow up for cases that are not coming, or new recruitment, or those who are not coming, for example, to the health centers where they're supposed to come, and also participate in other activities in the health huts. Next slide, please. So the experience on the task delegation here regarding the community base, we focused on social mobilization, as you can see on this chart here. Then targeting CAD agents, and they benefited from capacity building and equipment for these agents, and so the reinforcement of the capacity here and communication in the villages afterwards. Next slide, please. This is how we went into detail for these two levels, institutional first and community second. The state-of-the-art on these tools available for the training of ADBC on DMPA. Also the development, validation, and dissemination of national training tools for these agents on the DMPA. And also at the community level, we raised awareness of community members in favor of supporting the delegation of tasks in targeted villages. Next slide, please. As for targeting agents, we conducted a performance evaluation of the 4 agents in each village. We also, on the based on this evaluation, we targeted 2 best per village, one man and 1 woman. And then we raised awareness of 2 agents that were not selected for a better collaboration and support to agents selected for the delivery of the DMPA. Next slide, please. Regarding the process of capacity building for these agents that were selected, what we did first was a performance evaluation of the 4 agents in each village. And we upgraded a pool of trainers on the DMPA per region because it was important to make sure they could administer the DMPA. So this pool was constituted, and then of course there was a scale-up of theoretical training for these agents at the ISC level. So it was 3 days of theoretical courses on DMPA in local language and 2 days of practice, injection practice. And of course, there was a practical training for agents trained in the ISP, in the health centers. For 5 days, there was a training with 5 successful DMPA injections to FP clients so that we could validate the training within the integrated health centers. And this process was validated by internship. In an internship of, so after these 5 days of training, which was aiming at proving the ability to inject DMPA to FP clients. And of course, these 5 injections, if they were successful, then the internship was validated and the training was validated. But of course, those who could not successfully inject the DMPA for like 5 times, then of course they were sent back home to go back to training within with the supervision of their trainer and the trainer who was following up in the region. Next slide, please. So this process included equipment for CAD agents. So we distributed a pamphlet summarizing all instructions for proper administration of the MPA. A notebook was given to record information about the FP client, for example, first and last name, age, husband name, contact information, and date of injection, and which can then allow for data collection for activities. And then there was a stock of 20 doses of DMPA that will complement the other contraceptives. Next slide, please, that they have in the box. Next slide. The last step of this process was to communicate within the villages. So it was a reminder for the agent of the agent selection process to confirm that the capacity of the agent was effectively built, and that in order to reinforce confidence in those agents. So there was information about the training and certification and how they were trained and how they were certified, And of course, that they were supported, that they benefited from the support of the community members. Next slide, please.
Alors, en matière d'administration de DMPA-SC par les agents DBC, quelques responsabilités des agents ciblés pour cette approche.
So what is the responsibility of the CBD officers? So first, it's about collecting the information on the family planning clients, also verify if they are eligible, conducting the counseling, carrying out the injection of the DMPA-SC, and making appointments for the next injection. Next slide. So this process was closely monitored and supervised by different NGOs. It was done on a monthly outreach basis, but also on a quarterly basis by different trainers. So basically, they could follow up how it went within the communities. And by doing so, they collected data, they processed them, and send those out. Next slide. Ladies and gentlemen, now let's look closely at some of the results based on this experience. So in terms of mobilization, social mobilization, we ended up with a commitment of HR family planning stakeholders to determine the availability of national training materials and tools for those CBD agents. So basically, the idea was to really come to an agreement on those tools and what would be available. Now, with regards to community level, there was a commitment of community leaders to support those CBD agents by administering DMPA-SC in 140 villages in the regions that we've mentioned before. So the capacity building process has had as a consequence the upgrading of 78 regional trainers in those 3 regions. And then there was also a cascade training of 280 CBD agents, amongst which 80% of them were able to validate practical skills during the training period, and 20% of them did it as a follow-up within their own community. So by the end of this process, there was a significant improvement of understanding of the CBD officers on the DMPA-SC level, despite low level of education. And 280 CBD agents were able to work with equipment and contraceptives. So from the beginning of this new approach, starting December 2019 to August 2022, 280 agents performed over 13,000 injections, which basically provided years of protection. So the region of Zinder was key in these results, as you can see on the graph, because there were more sites. So more experiences, more injections compared to Tahoua, where you can see that the indicators are pretty low. And also because that region experienced the injections a year later too. So, and there are way fewer sites as well. So here you can see on this slide a few testimonies of some of the players involved in this process. The first one is from the Dosso region, It shows that since the training, the CBD agent has demonstrated his ability and aptitude to inject, which allowed him to seamlessly complete his course by injecting more than 10 clients. And after the introduction, some of the clients would go directly to them without going to the health hut. And as a proof, after 1 month of activity, he has performed more than 37 injections of DMPA-SC, so an average of more than 1 injection per day. So this was one of a trainer. Now, there's another in blue, there's another testimony from a client and who says that since we learned that our CBD agents can do the DMPA-SC injections, things are way easier. We have more choices in terms of family planning without having to walk miles to go to a health center. I just had my first injection with an agent in the village, and I'm happy. And I even look forward to coming back in 3 months for my next injection. So that is one testimony of one client who really appreciated the ease of use. So, of course, things didn't go as without any difficulties that there was to be expected. So there was first difficulty in targeting 2 out of 4 CBD agents for the DMPA in each village, especially regarding respecting gender parity, because sometimes it was interpreted as a failure of performance, but we reassured them and to make sure that they would work together with the other agents. There was also not enough mobilization of clients, family planning clients who would be interested in the DMPA-SC during a training period. So it was hard to identify potential clients or gather them. And because that would have been representative of the whole experience. And the last difficulty, the last challenge, after the certification of CBD agents, it was quite challenging to recruit family planning clients under the DMPA-SC to continue the practice in some of those villages. So we just had a hard time finding enough women who would accept to be part of this experiment. Next slide. What were the lessons learned? So the implementation of the process is not always easy with community workers who have no knowledge of traditional CBD. It's not. So the fact that there was a preliminary experience beforehand in hospitals, so that was a key issue. The inclusion of the need to be able to read and write in French, which was a selection criterion, facilitated a fast and effective learning of the DMPA-SC injection practice. And then the post-training follow-up of CBD agents on the DMPA-SC in their community was key here. It was decisive for the certification of those agents who did not validate the practical training within the health training period. So as a conclusion, the delegation of the administration of the DMPA-SC from health workers, especially from the health nets to CBD agents, is well underway in Niger. So moving from this Pathfinder pilot experience to a national scale-up in accordance to the family planning task delegation scale-up plan developed by the Ministry of Health. So the success of this plan, we need to take into account some of those challenges on the community level, especially during the identification of CDB agents, during the capacity building process, and even at the start of the injection of the CMPA by those agents. So after this experience, we have a few recommendations we would like to share with you. So we want to develop a plan for scaling up family planning task delegation and accelerate its implementation to boost the contraception prevalence rate in West Africa, but also take into account important factors such as level of education and prior experience with traditional CBD when targeting agents, so that they're responsible for injecting the DMPA at the community level. And then thirdly, explore the possibility of conducting qualitative studies in Niger, but in Africa also as a whole, to assess the level of satisfaction of family planning clients who have benefited from the DMPA-SC amongst CBD agents in order to further inform the process of scaling up delegation in West Africa. Next slide. Ladies and gentlemen, this experience of this task delegation through the DMBA was presented during the fourth forum of the ECOWAS, which was held recently, and we got the bronze medal for the presentation that we made. And you can see the certificate. Next slide. Next slide. Okay, ladies and gentlemen, this is the end of my presentation. So I want to thank you very much for your attention, and I am available to answer any questions or clarifying ideas or questions you may have based on this experience. Thank you so much for this presentation, Mr. Akim. Thank you for introducing or presenting the data drawn from this intervention for those CBD agents. Now we're going to move on to the question and answer phase of this webinar, and we will read the questions. Can you hear me correctly? Very well, doctor. So those are not questions more than comments. There's a question here. Somebody would like to understand the follow-up. How were you able to follow up those CBD agents? Did you hear my questions? Yes, absolutely. So that's the only question that was posted on the chat for now. Thank you so much. Thank you for the participants. So this follow-up took part on different levels. So first level, we worked with Pathfinder. Pathfinder performed the follow-up of each project, and those agents were recruited and trained. And there was also a supervisor or a trainer. So it was basically a trainer. And those trainers did the follow-up. On a second level, we organize quarterly follow-up by the people that train those agents. This enabled us to continue the relationship, like a close relationship with them. and to continue and to keep an eye of the implementation of this program. And on a third level, maybe a higher level, there were joint supervisions with other organizations to observe and monitor some of the interventions by those by those CBD workers. Thank you.
Celui qui a posé la question a trouvé la réponse et satisfait de sa réponse.
Yeah, I think we're very satisfied with this answer. So maybe we're going to ask another question. So there was also someone else who really carefully listened to you and wanted to know what motivated the choice of these three regions. So the choice of these three regions was on the basis of on how the result of the analysis, because these three regions had an experience that was very relevant to our project, and this is why these three regions were chosen. So as to integrate this experience. And as you can see in these three regions, all the districts are not involved. It's only the agents that are operational, functional. This is where we got statistics that we could use. Okay, I hope yeah, thank you very much, Akim. We're gonna ask you another question. There was also someone who was asking, are there activities that CBD agents do other than what you specified? So CBD agents that were in this experiment, they do distribution, community-based distribution. That is their main activity. And such as promoting family planning, and of course the administration of DPMC, DMPA, and the follow-up of those patients who are not coming anymore, as I indicated earlier. So the idea was really to focus on the family planning. And those agents have also this additional responsibility at the community level. Yeah, can you hear me? Yes. Okay, can we skip that? Can we move on? Okay, there's another question. The question is, it says, about CBD agents, do they have the responsibility of notifying incidents about products? So CBD agents who were involved in this experiment and who were very strictly followed and monitored, they have they have not notified any incident. And as you know, the administration of the DMPA is not so complicated. So it's not really, there are not many requirements. So it's not very surprising that the injections went fine and that there were no incidents, because the administration is easy, because they are focusing on the administration, on the injections, and the DMPA injection is not something complicated. So thank God, nothing for now, nothing happened, and there was no incident reported. And so whether it was linked to the related to the product or to the delivery. Thank you, Akim. Great. It was very clear. Thanks for this very clear agent. Thank you very much. But if there was no incident, we can say well done for this experiment. Well done. There's another question. Sorry, there are so many, but this experiment was very, people liked it. So of course, people get motivated and they want to ask you questions. So there was another question. What is the level of involvement of the different parties to make this experiment sustainable? Yeah, thank you very much. I'm very happy to answer this question. So this experiment, as you rightly said, and as you noted, was conducted within the health system at the peripheral level, like we saw before, for the training of the agents, but also for following up, the monitoring, and also for health officers who were involved in the whole process of our impact project, of course. And as you may have noticed, they supported our project. So in this context, we made sure that all the interventions were appropriate and at least supported by the system, and that there was a follow-up, and to make sure that what was acquired within this project was useful. And this is why we've always recommended the CSI head, the manager, that they need to make sure that if some of these agents can be used for other services, then of course it can reinforce just not cooperation among these agents, but also it also gives more confidence for the population. They trust more these interventions, and this is what happened here for this experiment. And we were very. We are really convinced that all the conditions were met and that everything was set up properly for things to happen in this way for the entire territory. And because, yeah, it was an experiment that was recognized at the international level, at the national level. So the idea was to scale it up to other regions. Yeah, thank you, Akim. Thank you very much. Indeed, this experiment was very successful. And thanks to this initiative, Niger was among the first one. I'm sorry, but there are more questions though. So there's someone who asked how CBD agents could manage waste. Okay, so about waste management, we took it into account during the training of those CBD agents, because each CBD agent, while there was the training and they got the stock of this injectable, they also got a box of waste management where they can safely eliminate waste. And so by the end, at the end of this administration, there is a mechanism of where agents meet and where they can meet in order to get the stock refill of their stock, and also to make sure that all the waste is eliminated within the health center. And so this is something that really allowed a good waste management and within this experiment, within the communities where it was applied. Thank you, Akim. There is also someone talking about the number. Why were there more women than men? Okay, so this question is very interesting, and I can give an explanation. The region, you know, the area where these are areas where men mostly went to cities to work, and this is why there were more women left in the villages, and it was harder to recruit a man because most men who can do that, they already gone. So within the villages, mostly women were left, and they really showed good involvement, and they showed that they were able to implement this process, and that they were skilled to do that. And something else I want to stress too is that this experiment is that it showed results that did not show a preference, of course, for women, or because what I mean is that this experiment did not, we did not, within this experiment, we never met women who did not want to administer DMPA, and or that didn't want to have it with a man or a woman. But a CBD agent, each CBD agent have experience, like they have an experience of 500 injections. So whether it's a man or a woman, patients feel comfortable, and experience matters, not gender. And so sometimes we tried to make sure that female patient would be taken care of by female, but it was not always possible, and it was not a problem. Thank you very much. We still have 3 minutes left, so I will ask the last question before we conclude this session. There's a question about how the agents were able to respect the choices. Well, in my opinion, so you mean what CBD agents could do to respect the client's needs? Okay, so my understanding was that how could we raise awareness for of the client? Maybe I'm not clear about the question, but what I think is that CBD agents had to deal with clients who already had a type of DMPA, and they were ready to get this injection. And those clients who were not, maybe they had another method and they chose to have the DMPA-SC, then these women were referred by health centers where it was already administered, and so these women were referred for specifically for these services, even before the DMPA-SC was announced within the executive under the supervision of the officer. So I'm hoping this is the question that was asked. I hope I replied properly. Thank you, Mr. Akim. Thank you very much. Thank you, everyone who followed us. We are not going to. We will never be tired of thanking the person who presented And we thank you, all of us, all of you, and of course the Minister of Health, and we are very grateful for this presentation and for this session. So we would like to thank all the agents at the central level and at the level of health huts and at every level, because without all of you, our work would not be possible. So we really want to thank you all. And so this is really the end of this session and about delegation of tasks, and I thank you very much. Thank you everyone. Thank you and have a nice evening.